Oh Lord, I won't come home, I won't come home to play. Oh Lord, I won't come home till the river runs dry, my friend.
Hi, I'm Micah Barbe, and I'm with the Panther production class at the OMTC. I would just like to take a moment to thank you for your time today and your willingness to do this interview.
Welcome. Glad to be here.
So, since COVID, so many things have changed. So, what is just some information about the pros and cons of getting vaccinations or not getting vaccinations?
So, the whole vaccination discussion is one of the big things that has come out of COVID. There were so many concerns about the COVID vaccine, so much conflicting information out there. Some of it was legitimate, some was probably misinformation. And what that has done is a couple of things. Number one, it did lead to some general mistrust of formal advice, both from federal sources as well as even from individual physicians. And it added to the already increasing number of people who were questioning vaccines for their children. The so called anti vaccination movement had already begun building some momentum prior to COVID. And the issues that we just discussed, plus the way the COVID vaccine was developed, the actual technology, as well as the information that was circulated about it, simply added fuel to that fire. And so since COVID, we have seen the vaccination rates drop considerably. There, or the flip side is the number of people who have been vaccinated has dropped. The number that have been unvaccinated has significantly increased.
And so, just what are some of the downsides to people not being vaccinated?
So there, I would put it in somewhat three categories. Category one is personal protection. We know there is no question that vaccines help help people keep from getting a condition. If they get the condition, it's generally a milder case. And the transmission of that generally is lower. So if I get sick, let's say I get the flu, but I've had the flu shot, my risk of transmitting it to you is somewhat less. It's not zero, but it's less. So personal protection is important. Transmission is important, and severity of the disease is important. Um, I'll come back around to that. The second big thing, though, is a situation called herd immunity. If no one in the population has immunity toward a disease, that disease will spread much more quickly through that herd. If half of the herd is vaccinated and has less chance of getting the disease, or it's milder, or it's slower to spread, then that actually protects some of those people that weren't vaccinated. And that is a substantial impact in pediatric vaccines, but also in flu shot, and we believe to some extent in the COVID vaccine situation 4 or 5 years ago. For instance, example of what happens when the non-vaccinated rate goes up in the pediatric population, kids don't get their recommended vaccines, then we see outbreaks of things like the measles. In fact, just recently, this last couple of weeks, there's been an outbreak of measles in South Carolina, and the infection rate has gone way up. The school attendance rate has gone way down because those kids don't go to school. The hospitalization rate goes up, and unfortunately, the death rate goes up. Children still die of severe cases of measles, especially those kids who might be immunocompromised, may not have good immune systems, can't fight off that virus the way you or I might. They end up in the hospital, and unfortunately, they end up dying. The same is true with the flu. But I would say on a larger scale, the flu season last year was particularly severe. There were more hospitalizations than there have been for the last 15 years and more deaths than we have seen. That, we believe, is due to the fact that fewer people got the vaccine. I would say that vaccines in general, especially adult vaccines, are most important for those who are most vulnerable. The more likely you are to get a severe form of the disease, end up very sick or in the hospital or dying, is greater if you have predisposing factors. We saw that back in COVID. We see it now with the flu, for instance, in people who have COPD, lung disease. If a 70-year-old with bad COPD gets the flu, they're a lot more likely to get very sick, end up in the hospital, or dying.
So, thank you for your very knowledgeable answers on those. So, just another, after COVID, so many things in the world have changed. So, what is the global future for medicine looking like? Like, how much information are we sharing with countries that have different policies on treatments?
So, some of the things I say now may be a little bit controversial, but the primary way that health organizations around the world are intended to communicate is through the World Health Organization. Now, I will admit that the WHO has a lot of problems, and some of those were really brought to the forefront during COVID. But since COVID, the US has pulled out of the WHO. We're no longer interacting with other countries around the world through that organization. That has kind of impaired some exchange of information. The US takes a ton of research information and advice and technology to the rest of the world. Some of that flowed through the WHO, the World Health Organization. Now our interactions are a lot more what I'd call one-on-one. It's us interacting with Japan, or it's us interacting with England, or it's us interacting with the Congo in Africa. And while that is good, it isn't perhaps as good as everybody sitting at the table together and sharing information. So that's one thing. The other thing that you brought up a little bit in some of the advanced information that you sent to me has to do with learning from other countries about what I'll call non-traditional medicine. Eastern medicine, for instance, things like acupuncture, cupping, massage, herbal, and other what I call non-traditional or non-Western forms of medicine. There is no question that there is significant benefit to some of those treatment modalities or ways to treat diseases. Many of them have not been researched as thoroughly as we typically do in Western medicine, but the information we do have is that some of those are very, very helpful. So I do believe that we will see the continued gradual incorporation of some non-Western treatment approaches as we learn more about them. And I don't want to jump ahead in our conversation necessarily in case we go this way, but AI is going to change the landscape of what we know about what treatments work, who they would benefit the most, and that will be applied also to some of these non-traditional ways of treating diseases. Herbals, for instance, we're going to learn more about herbals. We're going to learn more about probiotics and the gut microbiome and how that influences our health. So there's going to be some really neat developments in the future.
Yeah, and so just to delve into some of those more, you said Eastern types of medicine, the VA has started using acupuncture, and it's been shown to be a successful alternative to narcotics. So,
So go ahead. I'm sorry.
oh, sorry. So, so just like, what are your thoughts on that? Like, how is there any way that you could incorporate that into some of the practices over here?
So in the United States, things that get done are things that get paid for. And because some of these other modalities, like acupuncture, are not approved generally under most insurance plans, yoga, massage, again, some of those type of treatment modalities are not paid for, and therefore it makes it difficult for people to access those treatments. My feeling is, and it's what you have suggested, is that as those become more proven, they have the opportunity to be picked up or covered by insurance. Um, Generally speaking, they are less expensive than some of the more traditional treatments. And you might think that the insurance companies would pick up on that right away. And if they could do acupuncture and it costs half as much as some other current treatment, that they would jump on that. Well, that hasn't happened yet, but I believe we're moving in that direction. So that's what's hampered the uptake or the utilization of some of these other modalities.
So that's also a nice segue into the next question, which is, so the cost of medicine in the US has always been a challenge, and so it's becoming that way for more foreign countries as well after the COVID. So what is our role in the States as in the global picture as far as people who cannot afford healthcare and like getting it to them?
So, if we use medications as an example, and it could be extrapolated to other forms of treatment as well, let's use that as an example, and then we maybe cover some other kind of higher level things. So, in the press, you will see a lot about how the United States is paying more for medication. Same medicine bought here in Mountain Grove costs 4 times as much as the same medicine if you bought it in England. Um, I want to be a little more specific about that. That's kind of a shotgun statement.
Yeah.
In the United States and around the world, there are generic drugs and there are brand name drugs.
Mm-hmm.
And among the brand name drugs, there are brand names that have been on the market for 15 years that treat fairly common conditions. And then there are the very newer developed medications. These are the ones you see advertised on TV to treat psoriasis and ulcerative colitis or Crohn's disease. Those are extremely expensive, no matter where you buy them, but they are multiple times more expensive to the patient in the United
Mm-hmm.
States than they are in other countries. The flip side, and I'm going to give you a couple of statistics here, but I think they're useful. Generic drugs, which make up 90% of the drugs that are prescribed, are less expensive in the United States than they are in other countries. The brand name drugs, whether they're brand new or whether they've been on the market for a while, if they're brand name, they are in fact considerably more expensive, anywhere from 2 to 10 times, depending on the drug, here than they are in other countries. And so, because of that, there has been a lot of concern expressed by some that the United States is subsidizing drugs, the cost of medications, prescription medications in other countries. And to some
Mm-hmm.
extent, that is actually true. You may have heard that President Trump, for instance, wants to level that playing field and say to drug manufacturers, you can't charge us more than you charge England, or you can't charge us more than you charge Japan. Now, there are arguments for that, but going back to your question, does the United States have a responsibility or an obligation to subsidize low income countries? Now, I don't think we could call most of the European countries low income countries. So I'm not sure that we need to be subsidizing England or Germany or France, but that does not necessarily apply. And I do think we have some degree of responsibility to see that medications are provided to the underdeveloped countries at a somewhat more equitable price. Is it 10 times different? I don't know, but a somewhat more equitable price. So I do think we have some responsibility there to help. Now, one last thing I'll say, and then you can follow up if I didn't answer your question. I talked about how generics are less expensive here than other countries and brand name drugs are more expensive, and that 90% of the drugs that are prescribed are generic and only about 10% are brand name. How much do we spend on each of those categories? It is almost the opposite. We only spend about 15% in our total drug spending on generics, even though they make up 90% of the prescriptions. We spend 85% of the total drug spend in the United States on brand name drugs, even though they only make up less than 10% of the total number of drugs dispensed. So, to kind of wrap this up, the big challenge going forward for healthcare medication spending is trying to figure out how we get our arms around the cost of these very expensive drugs that do very good things. People with those conditions that I mentioned, ulcerative colitis, for instance, many cancer treatments are much more effective than the previous treatments, but they are way more expensive. They're literally can be thousands of dollars per month for some of these medications. Hepatitis C medications, for instance, are very effective, literally can cure hepatitis C nowadays, but the medications are expensive. Not as expensive as they were 10 years ago, but still very expensive.
Yeah, so I think that was a great explanation of how medicines are priced throughout the states and in the, global economy of other countries. But I'll just bring it back a bit to in the previous question, you had talked a little bit about AI and how that could be implemented into practices across the states, but it also could be implemented in other countries. So if you could just explain a little about how like it could be used in other countries possibly as like a global threat, like just how other countries could use it possibly against us.
So, the underlying question to some extent is what is the potential for bioterrorism? Okay, we saw the COVID pandemic, a novel and fairly highly infectious virus that spread throughout the whole world. There were some allegations that that might have been malicious, or if not malicious, at least a leak from a lab that was maybe doing bioterrorism research.
Mhm.
So we know the concept is out there, and we know there are groups around the world that would want to use something like a bioweapon rather than a conventional weapon. So the risk is real, but it is generally felt to be relatively low because it is somewhat difficult to, I would say, release and infect large portions at any given time. For instance, most of the research shows that any bioweapon is almost has to be airborne. Could be put in, let's say, the ventilation system of a skyscraper with, thousands of people in it. Spreading by water or spreading by food is number one, much more difficult. And number two, you can't spread it very widely at any one time in most cases.
Mhm.
So, to the extent that there is bioterrorism, it is likely to be airborne in origin. I'll answer your question, but then I want to follow up on that a little bit in terms of how do we protect ourselves against a bioterrorist attack. AI will, in fact, accelerate research and development across the board in healthcare. And one part of that, relates to what I'll call genetic engineering, modification of a pre-existing substance, maybe whether that's a biologic substance like a virus or whether that's a chemical substance. And so it will, in fact, accelerate that. And the fact that that AI cost to use that technology will be coming down steadily in the future, probably makes it pretty widely available, even for malicious or nefarious reasons. So it is a risk, and it will increase the risk, just as it increases the risk of cyber terrorism. Okay, we all know that. It increases to some extent even the risk of kinetic attacks,
Hmm.
development of drugs that could attack us, drug terrorism, different things like that. So, how do we protect ourselves? I'll make this short. Because future bioterrorism may look more like what we understand now as how very violent diseases spread. Let's say the Ebola virus, okay, spreads readily and is very harmful. The novel COVID strains were very harmful and spread very quickly. Protecting ourselves against an intentional threat is not very much different than protecting ourselves against a naturally developing threat. And so we learned a lot through COVID. We learned what works. We learned what doesn't work. We learned areas in which we were not well prepared. Did we have enough medical equipment? Did we have enough ventilators? Did we have enough personal protective equipment, gowns, masks, gloves? And the answer was no, we didn't. So we have learned from COVID some of the things we need to do to improve our preparedness for the next natural pandemic that comes along. And there will be one. It's not a matter of if, it's a matter of when. We're hopeful that it isn't anytime soon. Hopefully it's 100 years from now, but there will be one. And we can't specifically predict what it's going to be, but we know that the general preparedness applies pretty broadly across all pandemic, natural, or bioterrorism threats.
Thank you. So that was again another great explanation of how that could possibly take place in our modern world and even in the future. So just one more, I'd like to pick your brain one more time. So you've had a pretty long career in medicine, a successful one at that. Just any advice you would like to give to anyone, any recommendations for someone joining the medical field in the future, and what positions you could see as valuable coming soon?
Yeah. I have a lot of thoughts about that. I have been in on many conversations about it. There are a lot of physicians currently in practice or those already in the pipeline, medical students or residents in training, that are sort of wringing their hands and they wonder, is there even going to be a place for physicians in the future? Is AI going to take it all over? And my answer is AI is going to do more maybe than we even think it will. But I personally don't believe that it is going to replace physicians or other healthcare practitioners because for several reasons. For the foreseeable future, next 10 years or maybe even 20, we need interpretation of AI generated information. And physicians in particular are in the best position to look at that information and say, does this sound right? Does this make sense? And if so, how do I use this to the best advantage? Thing number one. Thing number two, patients will want a live person to be on their side, on their team for some time to come. They want a personal touch. They want me, the physician, to help interpret the type of information they're getting. So not only do I need to interpret it from the medical benefit side of things, risk and benefit, I need to help my patient understand how this can be used and what the risks and benefits are. So there's what is called shared decision making between the healthcare system, including the doctor, and the patient. That's highly valuable. The other part is it's going to be quite some time before AI can sense what I'd call some of the unspoken situations in the delivery of healthcare, the mood of the patient, the patient's family situation. Do they live alone? Do they have a supportive family? Do they not have any family at all? And those things all play into how an individual patient, what they want from the healthcare system and how they interact with the healthcare system. And that's exactly one of the important roles of the physician or another caregiver. There are other types of caregivers that will be important as well. That's how that will be our value, I think, for the foreseeable future. So I am not at all concerned about someone who says, I can't decide whether to go into medicine or not. I'm not sure there'll be a job for me in the future. There will be a job for the foreseeable future. Now, the greatest impact in potentially a negative way is going to be where AI has the least amount of some of those things I mentioned. For instance, pattern recognition, kind of writ large, looking at x-rays, looking at mammograms, looking at tissue samples under a microscope. Pattern recognition is extremely good with AI already, and it will get better. So will we need potentially as many radiologists in the future? Maybe not, at least not just to read a chest x-ray or an MRI. Now, there are still procedures that need to be done. If I see a mass on an MRI that was read by AI, number one, I ask the radiologist to say, does this look right to you? Is this something we need to go after? And if he or she says yes, and the best way to get to it is with a needle biopsy rather than sending somebody to surgery, we still are going to need an individual to do that for the foreseeable future. Might a robot be able to do that 30 years from now? Maybe. But between now and then, we need real live doctors and other healthcare practitioners to do some of those hands-on things. So that's a long way around the block to say I'm really excited about the future of healthcare, which we didn't really even talk about what AI may offer, but I'm equally excited about the new different roles and the tools that doctors and nurses will have as we help patients through their healthcare journey in the future.
Well, thank you again today for your insight, answering all these questions, helping explain some of the more in-depth topics and the, current global state. And
Have time for me to make one more comment that I didn't
yeah,
make back when we were talking about vaccines, and I'll keep it
mhm,
brief. So we talk about the anti-vax sentiment, people who are
mhm,
saying, I have more questions or concerns. Number one, talk to your doctor. It needs to be shared decision making. Don't just rely on what you see on the internet or what you hear from your friends. That's number one. Number two, our area of the country, Southwest Missouri, South Central Missouri, is generally, and I don't want to paint too broad a brush, but generally politically conservative. That group of individuals generally tends to have a slightly higher rate of anti-vax sentiment. And proof of that is that 5 years ago, before COVID, our rate of children that did not complete their vaccination series for reasons other than a specific medical contraindication, meaning a reason that they shouldn't get a vaccine, was about 5%. Last year, 2024, which is the last year we have full records for, that anti-vax situation had increased to 15%. It tripled in the last 5 years in Wright County. It doubled in Douglas County and Texas County, went from 5 to 10, and those two counties went from 5 to 15% in Wright County. So where people get their information, how they feel about trusting authorities, both medical authorities as well as maybe governmental authorities, has a huge role in somebody's decision whether or not to take a particular vaccine. So I just wanted to throw that in. We're right in the middle, high degree of anti-vax sentiment right now in our 3-county area.
well, thank you again, Dr. Barb, for your time and your insight. today and answering all these questions. So,
You're welcome. I hope a lot of people watch this. I hope it was good information. I think it was, and maybe it'll prompt them to bring up some healthcare issues with their doctor.